a little bit about what we are doing at LightHouse Little Learners. We're part of the early intervention system, and we're also working with kind of wraparound services for preschool aged children who might attend our playgroups or events. But services are all in the home and community. Everything is very much family-centered, just like other early intervention services. So this is really the opportune time for families of young children to understand what their child's vision diagnosis is, how that might impact their learning, how best to support them and advocate them before they enter the school system when services shift a little bit. So we're going to be taking a look at this broad scope of services from birth onward. So a lot of what we're doing is helping families understand how their child's, best learning modalities are working together. That early assessment when a parent is just figuring out what might be their child's learning profile. So it's a very important time for families to start to understand what their baby needs or their young child and how they can advocate for that going forward, including mobility, including technology that might be helpful, whether their child should be learning Braille or should be exposed to Braille. And also working with the rest of the professionals who are part of that child's learning team, whether they are therapists, early intervention, developmental specialists, the doctors and medical providers that are part of that child's support network, essentially. And we're really excited to be part of the LightHouse because we're also able to introduce families to this whole community of blindness professionals. Our CEO is blind. Our VP of programs is blind. So to be able to show families that there are so many opportunities for their child. They can access youth services, they can go to camp as a family, they can access adult services. So it's a very nice community that we're bringing families into, and that we're really excited about that. So our goals for our time together today, my hope is to kind of lay that foundation for you so that you have an idea of what does typical infant vision look like? How would we know if a baby may have a risk factor for a visual impairment, may not be using their vision typically, and what would that look like if that's impacting their baby's development? And what should you do? How can the doctor support the evaluation? How does the educational evaluation look? And then how do we support our youngest learners once we figure out what their learning profile is? So those are our goals for the day. And so before we can understand what a developmental visual impairment might look like, we need to understand what typical infant vision looks like. A lot of times it's very vague information that babies just don't see very well. And if a baby has any other type of disability, vision can be overlooked because it might just be thought of as, well, my child's not looking at things or paying attention in the same way as I expected because of this other disability, when in fact it may be vision. Sorry about that. An alert just popped up on my screen. I don't know if you could see it, but so first we're going to look at infant visual development. So in the very first days and months of a baby's existence, their visual system is starting to develop. They're hardwired to pay attention to faces. Faces and people and relationships are essential to a baby's survival. So it's just part of what is intrinsically infant development focus. So babies within the first days are showing preference for faces. And it's really important, I think, that we realize that by 6 weeks, infants have stable eye contact with their caregivers. This is pulled from, there's a reference in the next slide, but this is pulled from research about infant visual development, which is evolving all the time. So we're always learning more about how babies' vision is developing and what they're able to see. So yes, baby's vision may not be the same as an adult's vision, but if we have a baby who's 6 months old and cannot make eye contact, that's really important for us to recognize and to act upon early. Most newborns can focus at 2.5 feet. So while it's true that their best focusing distance might be that distance between, you imagine holding an infant, their head's in the crook of your arm, and that, 6 to 8 inches between your eyes and their eyes. That might be their best focusing distance, but they can focus from a couple feet away. So if you have a baby who's a few months old, and when you lean into the crib and they're not able to attend to you, to visually notice you, that would be something we would want to pay attention to. Within a few months, a baby is beginning to notice things moving, being able to follow something moving, being able to coordinate looking and reaching for something when you hold out that little rattle. And they're beginning to pay attention to your facial expressions. Many of you have probably seen, or done the experiment where you stick out your tongue and the infant notices this and does it back because those mirror neurons are developing. And so this is all happening very early. The baby's brain and visual system are growing very rapidly. And this is a lovely photo of a mom and a newborn infant. And you can see the smile on her face. And this is a infant just minutes after being born. She's attending to her mom's mouth. Her mom, you can imagine her as talking to this baby, gazing at this baby, and maybe the baby's too little to maybe make eye contact, but the baby is attending to her face. And this is just moments after being born. And this is the same baby 24 hours after being born. And you can see her gaze is on her hand. And this is how we see those very early brain development happen, where there are reflexes, infant reflexes that bring the hand and the eye together. And then as the hands come to midline, come to the baby's mouth, all of these systems are working together to integrate vision and motor so that you can reach for things and act upon things in the environment. So this is all starting very, very early for a baby. So then in the next months, we start to see depth perception developing. Color vision is really good after 5 months or so, and even in a baby who has a visual impairment, color may be something that is still accessible for them. Within those first 8 to 10 months, babies are beginning to recognize people and share visual attention, and this is a really key developmental milestone, because this means that not only is the baby looking at their caregiver, but they're also noticing that their caregiver is attending to them or attending to something else in the environment. Being able to notice what somebody is looking at and noticing that you're paying attention to the same thing is how we start to learn. It's how we start to build vocabulary. We hear someone is talking about something, we notice what they're paying attention to. Now, if a baby is not visual, is blind or has low vision, we still can teach babies these things. They still can learn all of these things, but we need to be aware that they're going to do it in a different way so that we can adapt how we interact and how we set up the environment so the baby can access these things. And then in your, later at the tail end of your first year, you're using more of those visually guided movements, the baby's starting to move more around the environment, scooting, using a pincer grasp, imitating things, and then moving into the second year where they're identifying familiar objects in their routines, pictures, really setting up the foundation for all of the milestones that are coming. Vision integrates with all of these different developmental areas for a child. So how does vision support learning? Understanding this piece helps us to start to problem solve. How do we need to change how we set up a learning experience for a child if vision is not the way they're learning? So our visual sense helps us kind of unify the information from our other senses. We hear something, we notice something that's happening at a distance, and we very quickly can evaluate the scene using our vision. We can assess the whole room and then explore parts of the room visually. And if a child is blind, we're going to do that a different way. But if you imagine stepping into a conference or a meeting, and you can very quickly, within seconds, know where should I sit, who's here that I know, where's the restroom, is there coffee on the table at the side that I could go access. You see this all very quickly. And then you can act on individual parts. And a child who has low vision is going to do that in a different way, maybe learning about the parts first and then building a picture of the whole. So our vision helps us understand where we are in space, where we are compared to other objects and people, what other people are doing, helps us build our vocabulary and understand the sequence of things that are happening. And we're going to talk a little more in detail about these different things in the next couple of slides. But this comes from Dr. Kay Farrell's work. It's a nice outline of all the different things that are happening with vision that we may not even be thinking about. Visual learning is very incidental. It happens, and you don't have to consciously necessarily teach a child to visually attend to something. They're learning all the time. So a child who is sighted has many exposures to the same experience, whereas a child who is blind and is learning through tactile or auditory senses needs to have the same access to those repetitive experiences in a different way. So it's not to say at all that we won't learn the same things if we're not using our vision, but to start to understand how just we automatically rely on vision, especially if we're sighted ourselves. We don't think necessarily of how to present things in a different way until we start to really consciously think about it. We know what questions to ask ourselves, and we know how to observe our child or the child that we're working with to see how it is that they're taking in information and making sense out of the world, because that's the key for us knowing how to then set up experiences, play, interactions for them, and how they will later use those strengths in their own learning profile when they go to preschool and in their future. So in this photo, you see a newborn baby gazing at a family, and they're all gathered around just looking at her. Now, when when we have a child and we're anticipating that this child is visual and we ourselves are visual, we are looking for that. We are looking for the eye contact. This is what we expect. You feel a connection through that eye contact. So when a family has a baby, enters their family who is blind or who is not connecting with them visually, it's so important that we recognize how then this baby is connecting and help the family recognize that. Maybe the baby is looking away from them in order to listen to them. That is how they're attaching. That is how they're making a relationship. That is how they're recognizing the importance of that parent or caregiver. But if you're not understanding that, you might think that your child is not attending to you, when in fact, they're doing what they need to do in order to pay attention to you, because you are their most important relationship. So it's really important for us to recognize what's going on, help families understand what they're observing, how to read their baby's cues that may be different than what they anticipated, and how to engage and interact with their baby so that their child can also access the things that they're trying to share with their child. For communication, we use our vision to even look at the mouth movements, to imitate. Watching someone's mouth movements and actually helps us hear. This is true for all of us. When you can see someone's mouth moving, if you're sighted, you hear them better sometimes, especially if there's a lot of distraction in the environment. And you do this subconsciously without even thinking about it necessarily. But it helps us understand communication. So if we're not using our sight to do that, we might do that a different way and teach parents to do that a different way. We talked a little bit about that incidental learning, how to bring those concepts that a sighted child might be observing us do, and tasks that we're performing, things we're preparing for them, in a distance. We might need to bring those to the child in a more hands-on way because they're not accessing them visually. And then when we think about how we develop concepts, how a very young child is sharing attention with us and observing what's happening around them, what people are doing, and beginning to imitate what they're doing. This is going to be different for a child who's blind or has low vision than a child who is sighted. So something as kind of basic to your daily routine as the sequence of events, let's say, that happen for you to prepare a snack for your child. Let's say your baby is eating banana, and if they're watching what you're doing in the distance, they're gathering all this information about a banana, a bunch of bananas, a single banana, a peeled banana versus a mashed up banana. If your child is not doing that visually, then we need to bring that experience to them. So a baby doesn't have a concept of a banana as being just a mashed up sweet food in a bowl, but a bunch of bananas, the sound it makes when you peel it off of the bunch, the texture of the skin, the smell, all of these things give us a concept of a banana that later would be, translated into maybe a representation of a banana if we think about early literacy. So these concepts that we're developing as a very young child lead to pre-literacy, whether that be tactile literacy or visual literacy or both. All of these concepts are part of our communication, pre-academics, all of that. Magical thinking is something we talk about in the field of blindness, because we want children to be active participants in their environment, and without just kind of passively being the recipient of things. So if, for example, you're a child who's blind and people just automatically hand you things to help you, you don't learn the same concepts in the same way. You don't learn to reach out and search for something. You don't learn to listen, localize the sound, and then reach for that object, to crawl, to move out into space. So we want children to not just think that everything is just present, but to have agency and initiative and explore in their own way as well. And that leads into movement. So vision helps a young infant be motivated to hold their head up, to look, to scan for things, to attend to things. Those early reflexes that we talked about that help us pay attention to our hands and the exploring things with our mouth as an infant, reaching out for things. There are visual reflexes that help with our balance. So children who are blind might have a little bit of a lower, say, core muscle strength, but these are things that they will develop. It might be on a different timeline, but they will develop it, and we can motivate those same skills in a different way. Holding your baby and being very close to their face and kissing them and talking to them up close in a tactile way motivates holding your head upright, just like the vision would, but we're doing it in a different way. Orientation and mobility is another specific part of the blindness field. It's a separate credential. It is the teacher who helps a child learn how to use a white cane, learn where their body is in space. So even as a baby, we are thinking about orientation mobility. Where is my body in space? Is an object touching my knee as I'm lying here on my blanket? And I am aware of that, and I am reaching for that based on my body and what's touching my body. And then I'm learning to reach for something maybe that's not touching my body, that's a little further away. So we're looking at all of these different learning modalities. And for a child who has low vision, we're looking at how to help them develop their vision if that's possible. For example, if a child has a cerebral visual impairment, which is brain-based, and we will talk more about different types of visual impairments in the next coming slides. But some visual impairments, the vision might continue to develop. Even in a child who has an ocular visual impairment, often the vision that they do have access to continues to develop. And so we're also looking at how to set up the environment in a way that is helping to develop their vision, helping them to access the residual vision that they may have, and then also helping them use the rest of their senses to make sense of the world and add to their vision. Okay, so here's a place for us to pause so that we can answer any questions about just that first sequence of visual development before we move into the possible visual impairments a child might have, and then later how we assess that, and then how we intervene. Okay. So,
yeah, we have a couple of questions. Do we need to read it? Okay, so the first one is, how can we recommend a specialist doctor to a parent if she or he asks for help?
How to recommend a doctor? Like,
yes. That's the question. A specialist doctor.
So, where we would typically recommend a child is to see a pediatric ophthalmologist. There are some optometrists, such as at UC Berkeley, who are also very good at assessing very young children or children who are nonverbal. So we're going to talk a little bit about what the doctor's role in this whole evaluation process is as well. And if the person is asking me for a specific recommendation for a doctor, it'd probably be good if they just email me directly so that we can have that conversation separately based on where they live and what they have access to. So did I understand that question correctly?
Yeah, thank you so much, Pam.
Okay. Yeah.
The next one is, what is the current people first language that we are using with sight impaired children?
That is a whole really interesting conversation, actually. People first is in early intervention. That's what we talk about all the time, is a child who's blind, a child who has a visual impairment. In the blindness community, there is a lot of advocacy for a disability first language. And the thinking there, these are adults who feel that their disability or their blindness is really part of their identity, that they that it's a blindness positive culture, almost like deaf culture is specific that way for some people. I think it's very individual. So I think it's important to know how a person themselves identifies with that. It's a very interesting conversation, though.
Okay, sounds
So
good.
we kind of do both, because we're in the blindness community and the early intervention community. So yeah.
Okay, thank you so much, Pam. Those are all the questions that we have by now.
Okay. Okay. So then when we start to think about vision evaluation, so thinking about what you might observe if your child or a child in your care might have a visual impairment. Are there certain risk factors that you should be aware of? When should you see the eye doctor? What might they do to help evaluate your child's vision? And how is that different from an educational vision assessment? And then we'll move into who's eligible for vision services. Okay. So the first thing is to just observe the baby's eyes, and what you might be noticing if there's something ocular in the eyes that is potentially needs to be followed up by a doctor, is if you see any discoloration in the pupils or a different shape of the pupils, any haziness to the eyes, anything where the eyes appear cloudy, or maybe they just appear different. Maybe the size of the baby's eyes are smaller or even larger. And I mean, not in the sense that people's eyes are all different, but in the sense where you feel like something is just maybe not typical. Like, for example, if a child has glaucoma and the pressure is building up in the eyes, that's something the doctor can check for, and the eyes might actually appear larger. So looking at if a baby is pressing on their eyes, or not rubbing their eyes in the sense of they're sleepy and rubbing their eyes, or having a little bit of irritation in your eyes. We all have that. But if you're noticing something that just is really consistent, seems abnormally challenging for that baby, that is always something just ask the doctor about, because a young baby can't tell you exactly what they're experiencing. But if the baby is like super sensitive to light in a way that doesn't feel typical, or if you see that the baby's eyes are rapidly going back and forth, not stable, roving eye movements, things like that. These are the things that you may observe in the baby's eyes. Or if the baby is a few months old and you see that the eyes are not aligned, these are things that you can follow up with the eye doctor. And these are the kinds of things that the doctor can very easily evaluate and determine if their eyes are healthy or not. Strabismus is something the doctor will check for that you would also be able to see very easily. This is the alignment of the eyes. And so there's terminology here in case you've heard this and you're wanting to know what does it mean. What is esotropia versus exotropia? It's an inward turn versus an outward turn. So this is just a quick reference for what you could be seeing if a child's eyes are not aligned. And sometimes it's very subtle. So you can actually look at it. Sometimes if you snap a photo, you can see a very subtle difference in the alignment of the eyes, or you can see that reflection that happens in the pupil. If you see something different from one eye to the next, that red reflex you see when you snap a photo of someone's eyes, you can look to see if you see differences there. If you shine a little flashlight and you see that the pin light is in the middle of one pupil and off to the side on the other, that is another way to check. And for some kids, it's not easy to see. It may be intermittent. It may be that there may be a little bit of alternating. The eye may go in on one side and then the other side. It may be different if the child is looking further away versus up close. Now, when you look up close, everyone's eyes come together. So that's a normal, accommodation that your eyes are doing. So what you would be looking for is if you see that the eyes are not aligned and it's consistent. The reason this is important is because in order for a child to develop binocular vision, where you can see things in 3D, you need to have two aligned eyes where there's visual pathways leading to the brain that are blending those two images together to make a three-dimensional image of the world. This is part of how you develop depth perception. And also, if an eye is turned and it's consistently turned, in a baby, the brain will just focus on the eye that's straight. And as the brain focuses on the eye that's straight, you can develop what's called amblyopia in the eye that the brain is not focused on. And that's where you see children having patching therapy, where they're patching the strong eye. It forces the brain to use the eye that it's not been using to build the visual pathways in that eye. So strabismus is something that the doctor definitely would monitor and that you can see when you look at your baby. And the other piece is looking at your child's visual behaviors to see if anything seems like it's not typically developing a vision, so that you know to follow up with that. As we talked about, not making eye contact, not being able to fix your gaze on a toy or an object, or follow the movement after your child is a few months old. Just not visually attending to things. If a child is bringing things very close to their eyes in order to look at them consistently. If a child seems to consistently look at things a different way, like maybe they're always tilting their chin up, or they're always turning to the side and looking to the side, these are things that you can watch for and observe in a baby's behavior just as they're playing and just interacting with people and so forth. that absence of reach, or a baby who takes only very brief looks and then looks away in order to reach for something, or a baby who seems to have trouble maintaining visual attention while they're using their hands or while they're listening. Almost that is like sensory information is being processed separately versus integrated together. These are the kind of things you might see if a baby is having more of a visual processing challenge. Anything where the ocular motor movement seems to be off, where a baby is having trouble shifting their gaze from things. If you hold up two things, can they shift their gaze between those two things? Or shifting their gaze something further away and then something up close. These are the kind of things we might see just as we're playing with a child or interacting with them that might indicate that they're having trouble using their vision. And for young kids, even kids who are a little older, even kids actually who are quite a bit older and are verbal, they may not be able to articulate to you that they're having trouble seeing. They may not realize that their vision is different than someone else's vision. Kids can be in school, in elementary school and older, and someone recognizes then that the child needed glasses. So we want to look at these things when the baby is early, developing as early as possible, because it could be something as simple as this baby needs glasses. And that will significantly help them develop their visual pathways in their visual brain and all of the rest of their developmental milestones. Okay, so we're making all these observations to see if we notice anything that might be different about the baby's use of vision. And then even thinking about are there any risk factors in this baby's history that might, paired with these different observations that we're making, might indicate that there could be a potential red flag for a visual impairment. There can be some visual diagnoses run in families. Even something as simple as amblyopia can run in families. Babies who are premature or who've had complications during their delivery, where they may have lost oxygen, for example, or been in the NICU and had significant impact possibly to the brain. The preemies have delicate, little brains, and things like brain bleeds can happen. Those types of things are things that don't necessarily mean a child has a visual impairment or will have a visual impairment, but they're things that we want to be aware of, because we're basically we're looking at all of this information and bringing it together. What is this baby's birth history? What is this baby's medical history? What am I observing? Am I observing anything with their eyes that seems different? Am I observing anything with their visual behaviors that seems different? So that we're putting this all together. So it's not that any one of these things means a child has a visual impairment, but we're putting it all together to determine what to do next so that we can identify things early. We also know that children who have a disability are at higher risk for visual impairment. So our children who are already in the early start system are at higher risk for having some type of visual impairment. So when that's the case, we want to be even more vigilant about watching for this, and screening for visual impairment is part of what is often done at an intake assessment. So it's something that can be on all of our radar, though. So I think everybody here is part of this network of evaluation, really, whether you're the parent or a caregiver or a teacher or an interventionist. We're all watching these babies together to identify any possible need for ongoing support. Okay. So how does the ophthalmologist fit into this picture? I mean, the pediatric ophthalmology organizations generally recommend that every baby visit the ophthalmologist when they're 6 months old. But we know that that doesn't necessarily happen. So if we are observing any of these risk factors, we want to make sure that we're advocating for that. Talk to your pediatrician, ask for a referral to an ophthalmologist, explain what you're observing and what you're concerned about, so that you can at least have the doctor check and be sure. So the ophthalmologist is going to be looking for the health of the child's eyes, whether or not the child needs glasses, whether or not there are any other assessments that need to be done. And if there are concerns about the child's health of their eyes, they may have other tests that they want to do besides just what they do in the pediatric ophthalmology office. And they can check to see if an infant needs glasses. Babies do get prescribed glasses, and it can make a significant difference for some kids. And so things you might want to think about asking the doctor when you're there is whether or not your child's eyes are healthy, whether or not your child has a vision diagnosis, and will that impact your child's visual development? Because some diagnoses are more benign than others. And so, and knowing what's going on with your baby's eyes also helps us determine what kind of accommodations or adaptations might help your baby. So all of this information is really helpful for the teachers working with you as well. And just to make sure things like glasses are not being overlooked. So actually asking the doctor, will glasses help my child? Some doctors have different philosophies about prescribing glasses. Some might think, well, we'll just wait until the child is in school. But for some kids, that might mean several years of not really having clarity in the visual information that is coming in through their eyes. So we want to give every child the best possible support to develop their vision to the best of their capability. And even just knowing, is there anything else that I should be watching for? And getting a copy of the notes. If your child does have a visual diagnosis, asking the doctor right there in the office if you can have a copy of the notes and seeing if they will print those out for you, because that will become important later on. Perhaps when you're asking for an educational evaluation, or perhaps when your child is entering school, preschool even, knowing that there is a vision diagnosis will facilitate getting those educational evaluations. And then knowing what treatment you should be providing, if any. How often should I be putting these glasses on my baby? When the baby's glasses are on, what is the baby's best focal distance? Are these glasses helping my baby see up close or in the distance? Because that makes a difference and helps you observe the impact that the glasses is having on your child or the child in your care. And then understanding patching and getting help for strategies to keep a patch on a baby. The doctor might be able to help with that, or an educator might be able to help you with that. So this is an important place to start, especially to make sure that your child's eyes are healthy. And this is a quick diagram about glasses and how this integrates with how this works for a baby. What does it mean to be nearsighted or myopia versus farsighted or hyperopia, or having astigmatism, which is based on the shape of your cornea, actually the front of your eye. So the way a doctor can tell if a baby needs glasses is by shining a light into the eye. They often will put drops in the eyes, dilate the pupils, shine a light into the eye, and they hold up lenses, and they're looking for how the light refracts inside of the eye. So you'll see in the myopia that X angle in the middle of the eye is in the center. It's not fully to the back of the eye, and hyperopia is in a different spot. So what the doctor is looking at is the angle of that light, which lens, when I hold up, corrects the angle so that it's falling in the proper place inside the eye. And that is how they determine the prescription for the glasses. So a child doesn't need to read an eye chart or tell you, like if you've gone to an eye doctor yourself and they hold up the lens and you say, that one's clearer, this was better, nope, not that one, this one. A baby doesn't need to be able to do that. A child does not need to be able to do that. The doctor can tell if you need glasses without your child being able to do that. Okay, so I think that's important to remember. And also, just because a child has glasses does not mean the child has a visual impairment either. Glasses correct refraction. They correct whether or not the image coming into the eye is clear as possible based on this refractive angle. If you have a visual impairment in addition to a refractive error that is not corrected, that's important to know as well. So if a child comes to your classroom or your intervention program who has glasses, it doesn't mean they have a visual impairment. But if your child has glasses, it also doesn't mean that their vision is fully corrected and there isn't something else going on in addition. And knowing why the glasses were prescribed is important. Sometimes doctors will prescribe glasses to a child to protect their eyes. For example, if they have vision loss in one eye, they may prescribe glasses just to protect the other eye. So it's important to know why the glasses were prescribed as well. Okay, so this is a little diagram of the eye and the visual system, the brain part of the visual system. And this I'm just going to briefly look at, just to basically the important point being that a visual impairment can occur in any part of this visual system, from an ocular condition where maybe the front of the eye is impacted, like the cornea is cloudy, or a baby can have a cataract, just like a person, we think of that occurring more in a senior, but a baby can have a cataract. So things can happen in the front of the eye, in the middle of the eye where all the blood vessels are on the retina. Something can happen with the vascularization, such as in a premature baby. The cells of the retina, the rods and cones, these are the part of your eye that converts the light that comes into the eye into an electrical signal that then goes to the brain where it gets processed. So all of these things in the eye need to be working in order for the information to come in to the brain to be processed. And then the diagram on the left, you see the eyes up here on the right, and these nerve fibers that come directly from the eye into the brain are the optic nerves. These are like a fiber optic cable with millions of cables that sends the signal into the brain. So a visual impairment can occur because of something with the optic nerve. Maybe it's didn't fully develop and it's small, so there's fewer fibers in there, such as optic nerve hypoplasia. If there was, say, an injury to the brain and the optic nerve was damaged, that can be part of a visual impairment. And then on this diagram on the left, you see all these little pathways that lead from the eye through the brain into the back of the brain, which is the visual cortex, or your occipital lobe. So that's where people think of your vision is processed by the visual cortex, by the occipital lobes, but it's also processed by many other parts of the brain. And that's because these pathways you see, all these little lines coming from the eye through the optic nerve into the back of the brain, crisscrossing at the chiasm and going through the brain. All of these pathways are responsible for sending that signal for processing. And it's getting processed in your visual cortex, but also in your motor cortex and your language cortex. This is how you identify an object that you see, how you make sense of something, how you move through the environment without bumping into things, how you plan to go from point A to point B. And some of these visual systems are subconscious and some of them are conscious, but all of this works together to create vision. So your eye is the camera and your brain is what interprets all of that. So you do really see with your brain as well as your eye. And so I'm going to show a quick picture super fast, and I want you to just type in the chat what you see. Oops. Oh, sorry. It's coming later. Thought it was next. Put that thought on pause. Okay. So there's also, this is just a quick list of the different types of diagnoses, some of which we've mentioned already, but babies can get cataracts, they can have glaucoma, they can have optic nerve conditions or retinal conditions. They can have conditions that impact their hearing as well as their vision. And that's really important because now we're talking about two major sensory channels that may have reduced input. You could have low vision and low hearing, and that requires a different strategies for learning as well. But the three most common pediatric vision diagnoses that we see here in the US anyway are cerebral visual impairment, which is based in the brain, optic nerve hypoplasia, and retinopathy of prematurity. Retinopathy of prematurity is the blood vessels inside the eye in a premature baby where the eyes haven't fully developed. There can be problems that develop with the vascularization. So every infant in the NICU is screened for retinopathy of prematurity. Sometimes you'll see in a report maybe that a baby had laser surgery, for example, that was for ROP. So sometimes that may impact the vision significantly, and sometimes the baby may be doing well visually. So again, it requires assessing all of these things together, and but it's a red flag to be aware of. And cerebral visual impairment is a very complex topic that could warrant its own complete webinar. Certainly, all of these things are. So we're kind of just overviewing all of these things, but so you can be aware of what to look for in a report. Okay. And this is just a quick diagram that comes from the work of Dr. Gordon Dutton and Dr. Chandna at the Smith-Kettlewell Eye Research Institute. This is a little bit about cerebral visual impairment, and it just gives you an idea of the complexity of the visual system. There's different pathways in our brain that process different types of information, whether it's something that's moving, whether or not it's our ability to pick out something from a crowded array of objects, or pick out my parent from all the other parents that just walked into the room to pick up their kids. This is part of our visual pathways, our spatial awareness, and then how we identify things. Can we remember the name of something? This is tied to our language brain. Can we recognize an object? Recognizing a face is an entirely different part of your brain. So there can be people who recognize objects but not faces. And this is all part of why we really take time to look at all of these things and how they work together, so that we can figure out what a child's individual learning profile is. Because there are definitely kids who show up in school later who have cerebral visual impairment that's not recognized. And a child can have good visual acuity and still have these challenges. An example that I always recall from someone's lecture or film was a child who was always late to class because she could not find the door to the room when all the other kids were walking by. It was too much sensory information. It was too much visual information for her to visually process. So when all the other kids were in class, she could then navigate her way to her door. So she was late every day. So instead of looking at, this child is late every day, why is that? Is this a behavioral issue? Being aware that there could be another reason for that, because children's behavior, we know, there's reasons for it, whether it's sensory or trauma or vision. So this is to help us build that foundation of awareness so that we can even start to ask questions and know what to ask of ourselves as we're observing a child, what to ask of our doctor, what to ask of our teacher when we're trying to figure out how to support a baby or a child. Okay, so that was the picture I was looking for in a second ago. So if you saw that flash up there, what did you see? What was the image that you saw? You can just type it in the chat. And we're going to have a question pause in a second. So I'm just going to give you a second to think about what it was that you saw. And if you weren't looking, I'll flash it one more time. So what was the thing that your brain automatically told you was in that image? So most people will say, I saw a face, I saw a smile. And you did, because your brain has that information stored. It has seen smiles and faces before. So your brain automatically made sense out of something that you saw and decided what it was. It's actually a picture of 3 birds flying over the water, but because of the lighting, because of the shape, because of the angle, and because of what you are already familiar with, your brain saw a smiley face. Possibly may have seen something else, because we're all unique and different in that way. And so it's important to know that how one person sees is not the same necessarily as how another person sees, because we're drawing from our own experiences, and we're drawing from what we are visually accessing when we say that we see something. Okay. Pause for questions before we go on to vision assessment and intervention.
Sure, we have a couple of questions. Here we go. My son has always had exotropia. It comes and goes. He is 15, and patching when he was young didn't work. Prism glasses give him a headache. It is not too late to fix. How can we fix it?
Well, the glasses giving him a headache is something definitely worth exploring. Sometimes prescriptions are not correct, or finding out from the doctor exactly when should my child be wearing these glasses. Is it only for near work and we're keeping them on when he's looking further away and that's what's causing the headache? Sometimes kids need breaks from glasses. You can have visual fatigue, and visual fatigue is something that can also happen just on a sensory basis, or if a child has cerebral visual impairment. And I don't know if that's the case, but visual fatigue can be a factor, and maybe that student needs breaks, throughout the day. So I think making sure the prescription is correct. As far as the strabismus, the exotropia, probably at that age, what the doctor might look at next, and I'm not a doctor, so I'm not advising or suggesting this is totally true without being a doctor or knowing this person, but they may suggest straighten the eye via surgery, strabismus surgery. And then you would be asking the doctor the pros and cons of that, and whether or not it is going to actually help your child's functional vision versus just making the eye straight.
Okay.
So that's been my initial take on that.
Okay, thank you, Pam. And
Yeah.
then the next
I'm gonna say one last thing.
I'm sorry. Yeah, sure.
Well, I'm thinking too about just the idea of brain plasticity. And they used to always say that, patching is something you do in the early years, and then it doesn't work anymore. But as research is showing that brain plasticity goes on past that the visual system is developing in older children as well, it might be that patching would still help. But even whether or not patching is recommended for a child is based on whether or not the actual vision is lower in one eye than the other, say due to amblyopia, not necessarily just because the eyes are not straight. So they're two different things almost. Okay. Sorry, go ahead, Brenda.
Sounds good. Thank you, Pam. Okay, so the following question is, are general pediatricians assessing for risk? I didn't take my infant to an ophthalmologist.
The pediatrician may screen for risk, or the pediatrician may notice, for example, if your baby has strabismus, but I think it's always good to ask the question. Sometimes even the ophthalmologist may not mention, say, trying glasses unless you ask the question, because they may be thinking, well, this baby's very young, let's just wait and see. So as educators, we're advocating for not just waiting and seeing, but actually proactively asking the question and trying the treatment, such as glasses, as early as possible if it's needed. So if you are concerned, I would just ask the pediatrician, can I please have a referral to the ophthalmologist? And again, these kind of individual scenarios, I'm happy to talk through with people outside of this forum as well, to have a little more in-depth chat about what they're observing and so forth.
Okay, thank you so much, Pam. I think those are the questions that we have by now.
Okay. Okay, so who is eligible for vision services? It's important to know the actual IDEA definition of visual impairment, which is any impairment in vision that, even with correction, which means glasses, adversely affects a child's educational performance or an infant's development. This is including both a child with partial sight or low vision and blindness. And the reason this is important to remember is because school districts and even statewide, there may be specific protocols that they have in place or that they look at, such as a specific visual acuity in a child, or a specific diagnosis that is or is not eligible for vision services. But what is important to remember is that it's not based on a diagnosis or a specific number like acuity. It's based on whether or not the visual impairment is impacting the child's development. or the child's educational performance. And OSEP, the Office of Special Education, which is federal, has put out even recently statements about this. So it's just important to know that this is the case as you're requesting evaluations or attending a meeting to find out what the results are of an educational evaluation. So if your child is birth to 3, you would contact a regional center or possibly your school district or a county office of ed. You can reach out to all of these resources. Each county is set up differently as far as how these agencies work together. So services can come from a regional center or a local education agency. And it again requires an intake evaluation to determine who the correct and best provider would be. If your child is already preschool age or older, you would contact the school district to request a vision assessment. And it's good to do that in writing, just to have that record. A school-based assessment should be done by a TVI, a teacher of students with visual impairments. And most likely a multidisciplinary team if there's other concerns going on, especially for an infant toddler. And you can also reach out to advocacy agencies or support networks like Parents Helping Parents if you need help kind of navigating these scenarios. And we get a lot of referrals from pediatric ophthalmologists. So if a child is in an area that we're not directly serving, we're all over the Bay Area and into the Central Valley, but if we're not in an area and we get a referral for a child, we will try to find a provider for the family as well, so that they know at least who to contact to get started. So so an educational assessment, just super quick about this should include all of these areas. They're going to review records and medical history, talk to parents and caregivers. It should be multidisciplinary, again, looking at all the different areas of potential concern in a baby's development, from, motor skills to cognitive development to fine motor, gross motor, communication, all of that. And all of that should be looked at by a team, an intake assessment team. Formal tools are used, and also informal tools by observing and just play-based kind of interaction with especially a very young child. And from there, you would, if the child is eligible, you would have either an individual family service plan if your baby is birth to 3, or an individualized education plan for a child who's in age 3 and older. The functional vision assessment portion of that is going to look at all of these things that we've been talking about. What is the child's acuity? And that doesn't necessarily mean reading an acuity chart or an eye chart, but what size of objects does a baby notice? At what distance? What does a baby's visual engagement and attention look like? Is there a lot of time that it takes when you present an object or your face? Is there a period of time that it takes for the baby to orient and then look, or the look's very brief? The vision assessment is going to look at how vision integrates with other areas of development, and what compensatory skills is a child using or needing, such as tactile learning and auditory learning and things like that. Looking at visual fields, is a child seeing things equally on the left and the right, or in the lower field? This is really tricky to piece apart, because say a child has a motor delay and their head control is not quite developed yet. Thinking about, is the head positioning in order to look at something? Am I lowering my head because I I can't use this lower part of my visual field, or am I lowering my head because I'm fatigued, or it's my motor ability. So piecing apart all of these things of how different visual fields are accessible or stronger or less strong for a child. How does the lighting impact? Does the child seem to see better in lower lighting, stronger lighting? How is color vision looking? Is a baby responding to only certain bright colors and not other colors? Is there maybe a difference in their contrast vision? If a child is finger feeding Cheerios and they don't see them on their white tray, does it make a difference if we put a black mat there so that the contrast is different? Does it make a difference if a toy is by itself or in a pile of toys, and how complex the visual environment is? How does sound impact that? How is a child moving around the environment if they are mobile? And how is vision being integrated into their routines and using their senses to make sense of the world? Part of vision assessment is also learning media. For a baby, we're looking at more of their sensory profile. Does a baby seem to gather information first by listening and then taking a look, solely by listening? Or are they very tactile? Do they touch things first and then take a look? How does that look in different environments with different types of objects? So we're really gathering up a lot of information. Later, even in preschool and up, you're looking at whether or not, what is a child's learning media? Are they going to be a print reader, a braille reader, both? How can auditory learning support either or both of those formats? Okay, and what accommodations need to be put into place, including technology? This is just a quick example of some of the types of vision tests that could be used by even a doctor or a teacher. So if a child can't read a letter chart, but they can identify a symbol, you might see a symbol test being used to look at acuity, or you might see what's called a preferential looking test, such as these striped paddles. It might be on cards in the doctor's office where there's stripes on one side and it's blank on the other side, or it's gray, and the stripes get progressively smaller, and they're looking to see whether or not that infant looks toward those stripes or not. Because if they see the stripes and they can move their eyes in that way, they would tend to just naturally look toward the stripes. So it helps get an idea of the visual acuity. And this is just an example what you might use for a child who's a little older, for a color vision type of test. So there's a number on this card embedded in green amongst the other kind of beigey tan colored dots. So color vision is not something that adults have color vision deficits or color blindness and don't necessarily know. So this is another thing that can be tested once a child is a little bit older. And for a baby, we're going to be doing vision assessment just with things they already have in their home, their preferred toys, objects that are familiar to them is always the best place to start. And then we might use some other little things just to see if there's a difference in the visual response, if something is shiny or something is lighted or something makes a sound. Is it different if something is a very bright color, solid color versus multicolored, or if something has a little movement? So we might bring some different types of objects to help evaluate how a very young baby just responds to different things. Different types of books, a busy book versus a simple book with one object on each page, things like that. Okay. So the last section we're going to go to is strategies to support learning. But any questions about that section that we just went through?
We don't have any questions, but I would like to post a small poll. It's just one question. If you could please respond to it. Is really short, then we would appreciate if you can respond to that. So you can continue with your presentation. In the meantime, they respond. Okay, thank you.
Oh, the poll. Okay. Super.
Thank you.
I'm going to there. Okay. Okay. Okay, so just a quick look at the difference between early intervention and preschool services. Early intervention is home-based, family-centered in the natural environments. And our goal is really to help the family, also the caregiver, understand, again, the diagnosis, coach them through supporting their child's development and modeling. And so there's some direct instruction, but also some a lot of coaching and support for the parent and the family. And in preschool, there's that transition happens at preschool. So then a child's services are school-based or center-based, more focused on individual child goals, direct instruction and group instruction, and how to support the child to access basically the curriculum being offered, any supports they need, direct instruction that they may need, accommodations within the context of the classroom. So a little bit of a different focus there. And one thing I wanted to really point out is that there is something called an expanded core curriculum that's specific for children with visual impairments. And this is something that applies to every child from baby through their school career. And the areas covered by the expanded core curriculum are compensatory skills, which includes Braille and any academic types of instruction that's needed. Social interaction. It can be different for a child who's blind to, say, engage in a group activity. They might need specific support in how to navigate those scenarios and integrate with their peers. And their peers might need support as well. How to make sure you use the child's name when you're talking, so they know that your comment is being directed to them, things like that. Sensory efficiency of using all of the sensory information that is coming to them to the best of their ability. Independent living skills, mobility, orientation and mobility, technology, even recreation and leisure, access to those opportunities, just like every other child, may need to be adapted for this child. And we want kids to be integrated into all of these opportunities with other kids as well. And how can we support that? And even career education is part of this. So even for young kids, how can we support them, even knowing what they might be able to do in the future and understand different types of careers out in the community, just like we would expose any child to these things. And self-determination is really that ability to understand what you need and advocate for yourself. And I like to think of the family's self-determination at this early age of birth to 3, because the family needs to feel confident that they understand their child's visual needs, their child's sensory needs, their child's learning needs, and how to uniquely support them so that they can articulate that to others, teachers, doctors, people doing assessments with their child. The family who can advocate for their child and expose them to all these experiences early is going to help that child self-advocate in the future to the best of their ability. Okay, and a quick word about Braille. Every child who is blind or has a visual impairment has a right to have Braille instruction. This is part of assessment. Not every child needs Braille. Some children who may be print readers may benefit from Braille because it may be more efficient for them. There are students who are older in, high school and college who discover that, yes, they can read print, but it's more efficient for them to use Braille. If a child has a visual condition that may be progressive, it's important to consider Braille because they may need that in the future. And also, I think just for us, we look at just early exposure. We don't know for a 2-year-old unless they are completely without sight that which learning channel is going to be the best for them. And it's important for that child to be able to have exposure and be able to help make those decisions for themselves in the future. So the more we expose kids to both, the more they have the opportunity to be part of that decision-making process. And the picture is just an example of a book that comes with Braille embedded in it. So there's print, there's Braille, and there's also a very simple image with nice contrast and some tactile element. So a child who has cerebral visual impairment might be drawn to those 2 big red boots. A child who's a tactile learner is going to have the Braille and the tactile element of the image. And a child who is sighted or has low vision is going to have the print and the image there as well. So exposing kids to all is great. And so I can see our time is running out. So I'm going to quickly zoom through these and you'll have these to refer back to, but hand under hand is a technique that we use to help guide a child's hands without grabbing their hands and directing them ourselves. It still gives a child the ability to come and go, but you're basically providing a model. It's shared attention in a tactile method. And you can see the parent doing this through a clapping game and with a book and a Braille reader in these images. We also are going to look at lighting, how to add lighting, like these Christmas lights this baby's playing with, or just holiday lights or just white lights that the baby's playing with. We might, if light is something that helps a child access visual information, we might dim the lights and add a flashlight or some type of lighting to draw their attention, and making sure we're being conscious about glare and not having things be competing for their attention. If a child is staring out a bright window, we want to make sure their back is to that so they can attend to what we're showing them and that we're using light to support them and not impede them. Color is another way that we can help an activity be accessible to a child. We might organize an activity by color, like the red and green bowls and the blue spoon that you see the little guy doing a cooking project, or the little gal who's reaching into her bright orange bowl on that white table. That bowl is helping her access this activity of having a snack. So color can highlight the salient features of something and also draw visual attention to something. Sound can be added to an activity. It's like the balloon or a ball, you can actually add little grains of say rice or something inside, or something in that makes the ball have sound. There are adapted balls that can be purchased as well. So there are adapted sports. Kids can play with sound producing balls so that they can play and do sports. And just incorporating music and sound into the environment is helpful for a lot of kids. Using real objects is very important because we want kids to have a concept of a real pear, a real orange, not just plastic representations, as they are using those objects into these activities that we are providing for them, where they can experience the sequence of events from beginning to end, from a lemon to squeezing the juice out to adding the sweetener and the water to the lemonade. You see this little girl participating in every step of that sequence so that she's learning something very fun and meaningful to her in a very hands-on way. Really integrating all of our senses, from painting with pudding instead of paint so that you can smell it and taste it and get it all over your body like this little guy is doing, to just being exposed to different spaces, dirt and rocks and grass and all of that. Experiential learning is super key. Bringing your baby up close to routines that you're doing. This little guy has his feet in the sink and is holding his toothbrush while his caregiver holds her toothbrush into the water as well. This is instead of just hearing the sound of the water, this is learning about what is a sink, what is a faucet, what does this sequence and this activity look like, where we can do it hands-on and repetitively to help a baby learn concepts. And everything you do during your day, from laundry in this example, can be used to build these concepts, from wet and dry, warm and cold, the sequencing of the task, concepts like in and out of the dryer or the washer, living skills, obviously, and your vocabulary and your communication and your social interaction during these everyday activities can be the best learning opportunity for a child. You don't have to buy toys or anything, just involving them in what you're doing every day is very, very valuable. Active learning is a specific learning philosophy that you can look up by Dr. Lily Nielsen. It helps us create an accessible learning space for a baby or a child that can be translated into curriculum in the future. This is just keeping objects in a stable space so a child can explore and learn independently in their own time, with repetition, without being directed all of the time. And orientation and mobility, you see this little gal is upside down. Just again, we've talked about some of these things, from where is my body in space to learning how to trail your hand along a wall to find something, or cruising along the couch with your hands on the couch to a toy that you find a step away, creating that map of where things are in your home and how to move toward them. And even before your child is mobile, these concepts are important. Where are things next to in my body? Using a wooden spoon to tap on a bowl is almost like a pre-K concept for a child, using an object to find something nearby them. And using your whole body to learn by actually sitting on the steps and feeling them and experiencing what is a slope, what is a step. Some kids will have low vision, may hesitate to move over a different color even, because they can't tell what that is. So giving them the tools to explore and experience that, in bare feet, touching with their hands, all of that is super important. Excuse me. And this is just a quick list. I know we're out of time, so if people need to go, that's totally fine. A quick list of activities and ways we might support a child with a cerebral visual impairment: by slowing down the pace, by adding lighting, by positioning things so that they're in a child's best field of vision, by creating structure for the activity and simplifying, just really thinking of simplifying the activity. From very early stages, it might be one object with one color on a solid black background with backlighting, and then you grow from there to more colors, more objects, multicolors, different types of experiences, and then layering in other sensory information. Maybe there's texture in that paint. Maybe there's sound in the activity. And making sure that you're pacing things so that the child isn't overwhelmed or very visually fatigued. Using your vision is a lot of work. So giving kids breaks is really important. And unfortunately, we won't have time to go through all of this. Like I said, this is a whole talk all by itself, but it's a quick example of how you might reduce the complexity. Instead of a patterned blanket with a pile of toys, a solid surface with 2 or 3 objects spread out from one another very much changes how a child might be able to access this visually, even tactily, especially in the beginning when they're still learning their vision. This is a example from a classroom, 2 different learning spaces. One is a busy classroom, and one is a little corner of a space that's set up specifically for a child where there's less visual stimulation going on. The activity is very organized. There's color that helps us understand what the task is, and it's all very much organized for a child who has, say, a cerebral visual impairment. This is an example of a parent using these strategies and positioning the activity so that his child is able to connect visual information with what she's doing together with him, with her hand in the visual field that she can best access the information. And this is that's a light box that she's using to make the paint brighter. And there's also texture in the paint to feel. And access technology or assistive technology is also part of what every child's plan can explore. This is an example of a child using a switch to turn on that mixer because she's participating in an activity, baking cupcakes with all the other kids. And this is how she's able to participate in this part of the activity. There's a list here of resources, some books and websites that you can look for if you're interested in learning more. And there's lots more. So again, reach out if you have specific questions. I have 2 flyers here at the very end. One is an opportunity to participate in a study about cerebral visual impairment. We are working with Smith Kettlewell Eye Research Institute to promote this, and we've created a questionnaire for a parent from a child birth to age 3, and Dr. Chandna is using a questionnaire for children, for older children as well. This is something you can do remotely and help support the research to learn more about cerebral visual impairment, and also help you learn something about your child's own visual profile. There's an email there, or you can reach out to me if you need more information about participating in that. And that's the end. There's my contact information again. So I'm sorry, it's always rushed at the end. I always find that that's the case, but there's just so much to talk about. And I'm, again, happy to talk with anyone further if you have specific questions or need more information about any part of this. Just feel free to reach out, and we're here as a resource for you.